but I lost very quickly my weight because of the hard work. I was very glad to have my mother there to meet Frank. And you can see here the residents and the fellows, most of them, they have been chairs in departments or professors all over America and also Europe. This is my dear friend Pietro Ruggeri. Pietro is here in the front, yeah, Pietro. So he was also in the SIM service. He's here on the right. And some pictures from the time, at the time that we got the Mark Coventry Award. It was the time that also I met my dear wife, Eva. And Frank Sim, at the time I was ready to leave, I actually never left Mayo Clinic because I was, every time I was there at the Mayo Clinic, his office was my office. So you see me working hard also in research, in papers, and writing chapters. Actually, with Frank, we did more than 40 articles and about 15 book chapters. We're very glad in 1998 to have in Athens the first Mayo meeting with about 8 or 10 Mayo professors. It was a wonderful meeting, and here we are in Santorini. In 2001 in Olympia with dear pathologist Uni and Carol Arndt here. 2001 was the year that my daughter was born, and we remember this meeting in Greece, and Pietro Ruggeri is here. We celebrated his birthday, sorry for writing the 60, but it was in 2000. Here you can see the next president of the American Academy. This is Christy Wember, who was the first woman who became president of the American Academy, and also Edmund Chow. In 2000, Frank Sim came to Greece, and he came to Greece not for a meeting. He came to Greece not for a vacation. You see here to be in Aegina, in the nice Temple of Aphea, and we are relaxing here in the boat. But he came to perform the first total femur replacement in Greece. So this was a very difficult case, and he came to do this together, just for the weekend. In 2003, Professor Soukakos invited him as a visiting professor, and here is in the University of Athens at the department at the time in CAT. And also he was invited at the meeting of the Hellenic Orthopedic Association. Some pictures of the time here with Mike Cabanella, with Bill Cooney, well-known professors from the Mayo Clinic. Here we are with another fellow and chair at McGill in Canada, Robert Tircott. By Frank Sim, two professors, Professor Wenger, radiology, and Professor Kerry Ingwards. They have been with him in most of the meetings, and they inspire all of us to have this team approach regarding the tumor evaluation and treatment. Here is another fellow from Frank Sim, Nicola Fabri, professor. He's now in New York. Here with George Babis. George, I think, is here. Professor Babis is here, yes. And Professor Parvizi, who is chair also in the Thomas Jefferson University. In Sweden, during the EMSOS meeting with Peter Chung, chair in Australia now, with John Healy in Bologna. And in 2013, we had the Mayo Oncology meeting in Athens, and it was a very, very good meeting. We really enjoyed the time at the Orthopedic Center for Education and Research, Panagiotis Soukakos. You see here all the team after the meeting. In 2015, I was president of the European Musculoskeletal Tumor Society, and here we had Frank Sim and also Louis Musculou, a very good friend of Frank, who is, both of them, they are considered to be the giants of orthopedic oncology. And of course, we enjoy with the family Frank is our family. In Orlando in 2015 with another fellow, Jorge de la Heras. And in 2017, I was president of the Ivings Orthopedic Society. And we can see here with all the fellows who have been at the Costa Navarino, very nice meeting in Japan in 2017, 2018 in New Orleans, 2018 at EMSOS meeting. And in 2001, as the president of the International Lip Salvage Society, we are here in Athens with his very well-known professor of orthopedic oncology, Mary O'Connor. We gave an award to Frank Sim for his contribution in orthopedic oncology. Recently, we just now have this deep dive course of musculoskeletal oncology and lip salvage, and of course is honoring Franklin Sim, who is still very active. He had a lot of participation in the meeting, and the meeting is continuing tomorrow. And I want to finish with that. Alexander the Great said, «Στους γονείς οφείλομεν το ζήν, στους διδασκάλους το ευζήν». This means that to our parents we owe the living, and teachers we owe a good living. Professor Franklin Sim, as being my great teacher and mentor in musculoskeletal oncology, many Greek patients owe you their good living. Thank you.
Αναγόρευση του τιμωμένου. Ανάγνωση των κειμένων του ψηφίσματος του Τμήματος, της Αναγόρευσης και του διδακτορικού διπλώματος από τον Πρόεδρο του Τμήματος Ιατρικής της Σχολής Επιστημών Υγείας, καθηγητή Γεράσιμο Σιάσο.
Εθνικό και Καποδιστριακό Πανεπιστήμιο Αθηνών. Ψήφισμα του Τμήματος Ιατρικής των Επιστημών της Υγείας Σχολής. Τύχη αγαθή. Πριτανεύοντος εν το Αθήνησι Εθνικό και Καποδιστριακό Πανεπιστημίο Μελετίου Αθανασίου Δημοπούλου, κοσμητεύοντος εν την των Επιστημών της Υγείας Σχολής Εμμανουήλ Πικουλή και προεδρεύοντος εν το της Ιατρικής Τμήματι Γερασίμου Σιάσου, έδοξεν ομοφόνος το τμήματι. Φράγκλιν Σιμ. Τα του Ασκληπιού έργα μέγιστα επιστάμενων. Την ιατρικήν επιστήμη έργοτε και συγκράμαση προαγαγόντα και την εαυτούν φιλανθρωπίαν πολλαχή επιδειξάμενον. Προς δε τούτης εύνουν της έλυση διατελούντα. Επενέσετε αυτόν και του της ιατρικής τμήματος διδάκτοραν επίτιμον αναδείξε. Το δε ψήφισμα τόδε εις μεμβράναν αναγράψε και τον του τμήματος πρόεδρον δημοσία εν τη αιθούση τη μεγάλη αναγνώντα και τα στιμάσαν υπόντα. Επιδούνε αυτόν, η ανημέρα η αναγόρευσης γέννηται, καθάνε νόμιστε. Εγένετο Αθήνηση, μηνός Ιουνίου 1η, έτους Δευτέρου και 20ου και δυσχυλιοστού από Χριστού γεννήσεως. Ο του της ιατρικής τμήματος πρόεδρος Γεράσιμος Σιάσος. Αναγόρευσης. Επειδή περ το τμήμα ιατρικής των Επιστημών της Υγείας Σχολής του Αθήνηση Εθνικού και Καποδιστριακού Πανεπιστημίου Φράγκλιν Σιμ, άξιον απέφυνε του επιτίμου διδακτορικού αξιώματος, ιδέτης των Επιστημών της Υγείας Σχολής του Ταπεδέξατο και ο πρίτανης τη της σχολής γνώμη επινεύει. Διατάφτα εγώ, Γεράσιμος Σιάσος, καθηγητής της καρδιολογίας, μοριακής καρδιολογίας, νυν δε του τμήματος ιατρικής πρόεδρος, χρώμενος στη δυνάμει, ειν παρά των πανεπιστημιακών νόμων και του τμήματος έχων λαβών, Φράγκλιν Σιμ, επίτιμον διδάκτορα του τμήματος ιατρικής των Επιστημών της Υγείας Σχολής του Αθήνηση Εθνικού και Καποδιστριακού Πανεπιστημίου δημοσία αναγορεύω και πάσας αυτός τας προνομίας τα στο πανεπιστημιακό τούτο αξιώματι παραπομένας απονέμω. Εγένετο Αθήνηση μηνός Ιουνίου 7η και 20η έτους 3ου και 20ου και δυσχυλιοστού από Χριστού γεννήσεως. ο του της Ιατρικής Τμήματος Πρόεδρος Γεράσιμος Σιάσος. Ελληνική Δημοκρατία. Πριτανεύοντος εν το Αθήνησι Εθνικό και Καποδιστριακό Πανεπιστημίο Μελετίου Αθανασίου Δημοπούλου, καθηγητού της Θεραπευτικής Ογκολογίας Αιματολογίας, κοσμητεύοντος εν την των Επιστημών της Υγείας Σχολής Εμμανουήλ Πικουλή, καθηγητού της Γενικής Χειρουργικής, προεδρεύοντος εν το της Ιατρικής Τμήματι Γερασίμου Σιάσου, καθηγητή της Καρδιολογίας Μοριακής Καρδιολογίας, Φράγκλιν Σιμ, αποδόγματος ομοθήμου της των Επιστημών της Υγείας Σχολής εις τους επίτιμους διδάκτορας εγκρίνομεν. Μηνός Ιουνίου, 7η και 20η έτους 3ου και 20ου και δισιλιοστού από Χριστού γεννήσεως. Ο πρίτανης Μελέτιος Αθανάσιος Δημόπουλος, ο κοσμήτορ Εμμανουήλ Πικουλής, ο του της Ιατρικής Τμήματος Πρόεδρος Γεράσιμος Σιάσος.
Περιένδυση του τιμωμένου με την τίβαινο της σχολής από τον κοσμήτορα της Σχολής Επιστημών Υγείας, καθηγητή Εμμανουήλ Πικουλή.
Ακολουθεί η ομιλία του τιμόμενου καθηγητή κ. Φράγκλιν Σιμ.
This one here? Yeah. Okay. Good. Good evening. I'd like to thank Hannes for those kind words and this beautiful ceremony. I'd like to thank you for this tremendous honor from the bottom of my heart. This gives me the opportunity to look back at the path that brought me to where I now stand, and an invitation to recount the excitement of discoveries past, failures made, and lessons learned. But most of all, to recount my tremendous debt to others, my mentors, colleagues, fellows, and of course family. The specialty of muscular oncology is very compelling, and while it asks much of us, it rewards us tenfold more from the close contact it affords us with our brave patients. In my mind, it also rewards our best traits, qualities of creativity, persistence, positive thinking, and teamwork, which is the quality I'm going to emphasize today, because with teamwork, all of the processes in the function of learning are funneled into a shared vision, and the result is to make a real difference in the lives of our patients. To begin with, I'll briefly retrace the path that brought me here, which Panis alluded to, because the more I think about it, it was by grace and against my best judgment at the time, and against the odds considering my serendipitous journey from a small coal mining town in Nova Scotia. I, for one, didn't set out to become a tumor surgeon. As I mentioned, I grew up in Canada, where everyone knows that the noblest path a young man can take is to grow up and play professional hockey. Well, lots of kids play hockey in Canada, so that's nothing new. But lots of kids also have to sit back and watch as their love of hockey takes a back seat to getting a real job. Well, that happened to me also, but it just took a little longer to get there, probably because of my early success in the field. When I was 16, our junior team knocked off a powerhouse team from our provincial capital to win the provincial championship. So from then on, I knew exactly what I wanted to do, but when the National Hockey League scouts came to my home and offered me that career path, my mother said, "No, son, if you're going to play hockey, you're going to play hockey at university." So off I went to Dalhousie University, where I studied science and medicine, but I think I majored in hockey. And I had continued success at the collegiate level. And then after medical school, I came down to Minnesota to do my fellowship in orthopedics. But I was very pleased to know that I could play professional hockey in our town with a team that played United States Hockey League. I must say, during those first 2 years of residency, I didn't attend many seminars or journal clubs, but it probably didn't matter because most of my mentors and professors were at the game anyway. So when I came on staff in 1960, I continued to play senior amateur hockey in Minnesota, which some of you may know is the state of hockey. And then that was followed by enjoyable hockey, what we called old-timers or beer hockey. So my last outing was against a friendly match against our tumor colleagues at the University of Toronto. And I must say, these two big guys in blue were the ones that led us to a victory over Toronto, Matt Hodek and Peter Rose. So while it was clear I wasn't going to reach the top of the hockey world, many of the lessons I learned from my mentors, coaches, trainers would have a powerful influence in my surgical career, particularly the need to have a strong team with diverse skills. Now, teamwork might seem like old hat in today's era of surgical subspecialization, but it was a relatively novel concept in those early years. So when I came on staff in 1970, tumors at Mayo were done by a number of surgeons in a rather ad hoc manner. So my friend Doug Pritchard and I joined at the same time and worked with our mentor, Jack Ivins, who was a fantastic surgeon and a visionary. And we were subsequently joined by Tom Shives and Mike Rock. Meanwhile, at Mayo, Jacksonville, and Scottsdale, the top players in our scorecard are Mary O'Connor and Chris Beauchamp. So we were joined at Mayo in 1996 by Michael Yuzemski, and a decade later, Peter Rose joined us. So that's when the evolution of our complex spine and sacral practice began, and I'm going to recount some of the early years. Of course, we're very well taken care of for decades to come with this bright new cadre of musculoskeletal tumor surgeons. One of the great joys I've had over the years is to work with such a fine team at Mayo to establish this team approach to meet these challenging problems. I think all of us at teaching institutions try to mentor and inspire a new generation of tumor fellows to advance the science. And Mayo has done a very good job with that, with our fellowship program, which began in 1972. We've had 1 or 2 fellows each year, and I'm very proud of the accomplishments that the Mayo Tumor Fellows have made in the field. I'm particularly proud of our international fellows. We have international fellows from around the world, but here's a few select ones that become leaders in the specialty. I'm delighted to have many of my friends here tonight. Now, Pan has mentioned the diverse practice we have at Mayo with people from around the world with different cultural traditions, and making them understand the treatment they receive, and promoting diversity in the orthopedic field. I was awarded the Diversity Award by the American Academy of Orthopedic Surgeons, which is today the most cherished award that I have had. So as far as practice goes, I was fortunate to practice during a time over 5 decades where I could witness the evolution and see the factors that are important in today's standards of excellence. But it wasn't always that way. As I mentioned, when I joined the staff, the results were very dismal. Most patients required an amputation, and the cure rate was 15 or 20%. So there may be value in reflecting on the events of the past in order to understand our current techniques and future advances. When I was in training in the late 60s, emphasis was on clinical pathological correlation, defining and identifying tumors as distinct entities. Now this gentleman is a world-famous pathologist at Mayo who was one of the pioneers in this area. Subsequently, rapid advances in related fields impacted our specialty. By the early 70s, we were still using X-ray, bone scan, angiogram to diagnose and stage tumors. But by the mid-70s, CT scanning was beginning, and a decade later, MRI was proven to be very useful. But I think the biggest advance was the development of effective chemotherapy. And the first report was from Roswell Park in Buffalo, New York, where they showed the efficacy of adriamycin in metastatic pulmonary disease. By the mid-70s, there was a doubling of survival rate with adjuvant chemotherapy. In the early 80s, the Memorial Group were developing the concept of neoadjuvant chemotherapy. So it became obvious that we had to improve our reconstructive techniques to improve the outcome of these limb salvage procedures to make them better than amputation, which was the alternative. So the American Musculoskeletal Tumor Society played a very important role in developing reconstructive techniques. And as Pan has mentioned, these 17 surgeons met in Boston to discuss the concerns of the time. And the biggest discussion element was at what level do you amputate the limb, because there was great concern for possibility of metastatic skip lesions in the bone. So unfortunately in that era, many patients had unnecessary, rather mutilating disarticulations. I remember at that meeting, the minutes read there was a very strong discussion in a somewhat adversarial manner, and hence it was called the Piranha Club for the first couple of years. It's interesting in those early years that each center had their own preferred method of reconstruction. Bill Anaking is one of the fathers of musculoskeletal oncology, so if you went to Florida, he recommended resection and arthrodesis. In Boston, Henry Mankin was a champion for osteoarticular allografts. And at Mayo in New York, we were pioneering the first generation of tumor prostheses. Well, the early results were promising, But we had many failures, mechanical problems, fracture, loosening, dislocation. And as a result, the Mayo Group organized the first international workshop on the design and manufacture of tumor prostheses. We invited surgeons from around the world to work with material scientists, bioengineers, and manufacturers as part of the limb salvage team to solve these challenges. Subsequently, lessons learned from physics, engineering, and metallurgy improved the application of tumor prostheses. Bioengineers were very important in their developments. Edmund Chow is a famous bioengineer and pioneer from Mayo, developing modularity, joint design, and so forth to improve function and durability. As well, close collaboration between clinical practice, basic science, and bioengineering expanded the range of reconstructions. And biological reconstructions were prominent then, and they're still some of the most important role in limb salvage reconstruction. This is one very prominent useful technique that was developed at Rizzoli and popularized at Mayo by Matt Hodek, who is here today, and our plastic surgeon, and designed to do a transepiphyseal resection close to the tumor, but preserving the articular surface. So reconstruction is done biologically with intercalary allograft combined with a vascularized fibular graft. And because of the biological reconstruction, she was able to return to volleyball. She's an elite volleyball player, and she was actually highlighted on CNN on her return to the sport. Now, musculoskeletal tumor surgeons work with the entire spectrum of surgical disciplines. Sometimes we go to their room to help with their cases, or they often come to our room with our challenging cases. Here's a case where a patient has extensive involvement of the anterior pelvic structures. And these 5 teams from different specialties work together to achieve clear margins and restore function. As I mentioned many times, we go to their room. Here's a case Peter Rose did with their thoracic surgeon with a complex Pancoast tumor involving several ribs. And the 3D life-size model has been a great help in these cases, because now, during surgery, we can take direct measurements and know the precise extent. So now surgery can be carried out in a more conservative manner with tumor-free margins, but preserving the clavicle, brachial plexus, and femoral nerve. Tumor surgeons work with all of our orthopedic subspecialists because of their improved knowledge in their own anatomical area. And I'll illustrate a couple of cases to show how this works. This was a case probably from the 80s, and our fellows of that area, Mary O'Connor and Tim Dameron, did a very excellent assessment and biomechanical analysis. And they showed that we were achieving good distal function, hand and elbow, but the shoulder really wasn't very good. But today, working with our shoulder surgeons, we can use more complicated, sophisticated techniques, as in this case, the reverse total shoulder, which greatly improves the outcome. This young 14-year-old girl who required a almost near scapulectomy. And in those days, we would be happy to get a clear oncological margin, and we would accept her functional limitations. But today, working with our shoulder team, a more sophisticated reconstruction is carried out with a scapulothoracic arthrodesis, increasing bone contact with allograft or vascularized fibular graft, muscle transfers to restore function. And here she is a year later. She wanted to be a teacher, so she could write in the board and do all the activities with her occupation. This last case in this group is a 6-year-old female, probably one of my favorite patients. She required an extensive anterior pelvic resection of the iliopsoas, and 10 or 12 centimeters of her femoral nerve, which was reconstructed with Rob Spinner, who's our peripheral nerve surgeon. And here she is 2 years later, back as the star of her youth hockey team. Great moves. So that didn't slow her down much. Now, sacropelvic tumors we talked about today, they're probably the most difficult challenge we face because the anatomical complexity and the difficulty achieving clear margins, and hence the importance of a team approach. When I started my practice, the results were dismal. Most patients required an extensive mutilating hemipelvectomy, whereas about that time, case reports, small series began to appear, suggesting the possibility of internal hemipelvectomy, limb salvage. So currently, of course, this is the standard of practice today. But there were efforts needed to be done to improve the results so that the internal hemipelvectomy procedures had satisfactory function. And Mary O'Connor, in a classic paper, reviewed 60 patients with limb-sparing surgery at Mayo, and she recommended from her study that the best technique is individualized for each patient and determined by the functional demands of the patient and the extent of resection. So during those years, there were a variety of techniques that were being used, and each had their own advantages, but also their own set of problems and limitations. One of the controversies in that era was whether you should do a simple pseudarthrosis, attach the limb, or a more detailed stabilization. So our fellow at that time, Dr. Bruno Fuchs, who's now in Switzerland, he settled that issue with a very elaborate study, looked at 32 patients with clinical analysis and biomechanical gait analysis, and he found that both techniques were equally good if you choose the proper patient for the proper technique. But here's another classic article by Dr. O'Connor and Dr. Courtney Sherman, who's at Mayo Jacksonville, and they looked at that same group of 60 patients with 30-year follow-up, and they found that the results, the reconstructions we were doing in that era were very favorable and were durable, and almost 3/4 of patients remained alive and free of disease at 30 years. So subsequently, improved technology was stimulating the development of pelvic prostheses to restore function in the pelvis. At Mayo, our initial approach was to work with our reconstructive surgeons with tantalum ingrowth prostheses, and the results were very promising. Matt Abdel reviewed our early series and published it in the journal and found the results were excellent. But the problem was it required considerable custom carpentry to fit the remaining bone to the implants. And currently, my colleagues, as well as Dr. Ruggieri, Dr. Papagalopoulos, are utilizing this technique, real-time 3D printed implants with computer cutting jigs to make precise fits. And this is resulting in dramatic improvements. The last area I want to cover is sacral tumors, because there's still a high local failure rate, which adversely affects survival. And there are a number of reasons for that, particularly the inaccessible location and the large tumor volume that they can achieve. But Bruno Fuchs did a classic review of 52 patients at Mayo and concluded that the problem is we need to do more radical surgery to achieve wide clear margins to obtain local control. And other centers, particularly the two papers from Dr. Ruggieri, classic papers, emphasize this. And so a current approach in these tumors is to do more radical surgery, to achieve clear margins. And it might be removal of the entire sacrum, lower lumbar spine, wing of the ilium. So we've had some experience back in the day, I should say, or early days, and some might call this pioneering. I think of it as flying by the seat of our pants. But this was our first case in 1982, a young man with a malignant giant cell tumor. He had resection of L5, entire sacrum, and wing of the ilium. Now, in that era, we didn't know whether you had to reconstruct these or not. There were some studies from Sweden suggesting perhaps you didn't have to reconstruct them, but their resections were always much narrower, it seems. So we didn't reconstruct him. We kept him down in a Foster frame for 6 weeks, and when we did get him sitting up, his spine fell into the pelvis, and he'd get inferior vena cava syndrome. So he had to be reconstructed, and we had to use some of the techniques we had at that era. Like all we had was Harrington compression rods and a lot of bone graft. So we were ready for our next patient. A year later, this is a young vascular surgeon from New York. He has a neurofibrosarcoma. He's already had a decompressive laminectomy, and he was offered a hemicorpectomy in New York. So he came out and had local resection, which included L4, 5, and the entire sacrum, wing of the ilium. So he was obviously reconstructed early, again with the techniques that we had, compression rods, bone graft. But the evolution of the reconstructive techniques really improved the ability to do these extensive resections. This is the 90s, we're using the Galveston modification of a Lukey technique. In the 2000s, we had a great progress with the rod screw method. But my colleagues took it a step further, developing what they called the cathedral method. And fibular grafts, sometimes vascularized and radiated situations, were placed from lower lumbar spine to the anterior pelvis to reinforce the posterior construct. Studies in our biomechanics lab showed that this improved resistance to failure twice over the posterior construct alone. So here's a typical case. A young man with a sacral chordoma required a total sacrectomy. Here's his reconstruction, dual rods, fibular grafts, and 1 year later he has a solid fusion. These reconstructions have to be individualized and tailored depending on the extent of the tumor. Here's a young woman with a malignant tumor extending to L4. So she required a total sacrectomy and removal for lower lumbar spine. And this was reconstructed with the proximal femur from the amputated leg, which is brought up as an intercalary graft to bridge the defect. And this went on to solid fusion. Here she is a year later in her snowmobile. Here she is 3 years later walking down the aisle in a prosthesis. And here she is at 10 years visiting with her surgeons to celebrate her 10-year cancer-free checkup. So my colleagues took this work a step further and analyzed a large number of sacral tumors according to a novel Mayo classification, where we could select the best reconstructive method and predict the functional loss and functional outcome. Because of this work, we were awarded the very prestigious International Hamden Award, and I had the honor to go to Dubai to accept this award on behalf of my colleagues. So I think it's clear in these malignant tumors it requires a team that's prepared, skilled, but also has a hate-to-lose attitude in order to have an aggressive approach to meet the challenges and achieve success. Now, this concept of teamwork was present at Mayo from the beginning. This is an excerpt from Dr. William Mayo in 1910 that he gave to the Rush Medical School Convention. He says, as we grow in learning, we more justly appreciate our dependence upon each other. In order that the sick may benefit of advancing knowledge, union of forces is necessary. So I must say that all of my colleagues and friends that are in this field, we're all very pleased with our career choice, and I might add even myself. And one last word of wisdom: with the complexity and difficulties in our practice, it's very important to treasure our successes. It's certainly a privilege to attend to our brave, aspiring patients. I want to thank you again for this great honor and for your attention. Thank you.